Here's a case of a cataract and a DMEK shown at 1 times speed. Here we are making a 1 mm stab incision. I like to do these pretty vertical on combined DMEKs, that way we don't overlap. Here's some intracameral lidocaine going in. And next we have a dispersive viscoelastic. I like to use Viscoat. And I use the cannula to stabilize the eye as I make a 2.4 mm incision. On my triple DMEKs, I try and do a pretty short wound and pretty peripheral wound, again so I don't overlap when I'm stripping Decimes. Here I'm using the MST capsulorhexis forceps. I like these because they have kind of an all-in-one function. You can make your capsulotomy and then do your continuous curvilinear capsulorhexis. In combo DMEK, cataract and DMEK cases, I like to make these a little on the smaller size, down to 4.5, just to make sure that the IOL doesn't pop out of the bag as I'm flattening the chamber to unscroll the DMEK. Next I go in with some BSS to do some hydrodissection, and I get a nice fluid wave there. I'm not getting a great spin here, and I know I'm going to pay for this later when it's time to remove the cortex, but I decided to go ahead and just start with my phacoemulsification using a 2-4 Centurion here, and I'm doing a little bit of grooving and cracking, and I most of the time do divide and conquer here. I think I do a little bit of a combo divide and conquer stop and chop. I use a Connor wand as my second instrument, and getting to the base of the groove there, spinning, and another sculpt, and then crack it into quadrants. And here's a neat little move I picked up from John Berdahl, sneaking behind the quadrant there and pulling it forward. That way it's right in front of your phaco tip. You don't have to go chasing it. Then I make sure that the next quadrant is freed, and then continue spinning this heminucleus all the way around, and then I go around to the equator and chop, just a dry chop. I'm not really engaging with that nucleus at all, just kind of pushing the phaco piece in and doing the chop. Here I am mostly using the Connor wand to do most of the work. You can see the phaco tip is staying mostly in the center at the iris plane here, and nicely breaking up this 2+ NS cataract. Once that's all out, I come out and I switch to irrigation aspiration. And now's when I pay for not getting a really great spin on that lens after my hydrodissection. With a good hydrodissection and a spin, this cortex comes out really easy. And here I have a little bit of an epinuclear shell, and it's not a problem, but just takes a little extra longer. You can see it coming as more of a shell rather than nice pieces. But just keep working at it. And I really like this soft tip here that has that little ridge that I can use to position myself on top of the capsulorhexis and kind of tent it backwards and get to that subincisional area pretty easily. And I continue to just kind of work at it, and slowly but surely it's all coming to me. Here's that last little bit, and I'll do just a little bit of polishing here. I like to do a little bit of polishing, mostly just because I'm getting some fluidics in the eye and making sure that there's no pieces left behind. The last thing you want is a retained cortex or retained lens fragment in a combo DMEK case. It's just kind of a bit of a nightmare. Here I am using the IA tip to enlarge my peripheral iridotomy that was created preoperatively, and I'm actually going in here and just ensuring that it's enlarged with some cohesive viscoelastic, just pulling on it a little bit, just making sure that PI is patent. That's the best thing to do to prevent a post-op day 0, post-op day 1 pressure spike. Inflated the capsular bag, and now I'm putting in a Acrosoft lens. These are great lenses, nice monofocal lens. When I combine this with a premium lens, I will do this at the same time, an LAL at the same time, but usually like to do monofocal. So here I am stripping Decimes membrane, and I haven't marked out the cornea at all, but I know that I want to strip at about 9 millimeters for an 8 millimeter graft. And if the cornea itself is about 10, 11 millimeters, then I know if I go just half a millimeter inside the limbus, I should be good. And this one's stripping pretty nicely. The the more advanced the disease, the nicer this Decimase membrane just strips right off for you. And it's really coming off in one big sheet, and I'm just kind of twirling it around and pulling it right out there. And next step is to remove all of that viscoelastic. So I just go right back in with the IA. And I like to go behind the lens, just making sure that I've got all that viscoelastic out. It's easy enough, and if the lens isn't letting you get behind it, then I don't push it too much, but I think it's important to get behind the lens, and all of it's removed. And the next step is to make that pupil smaller, because the last thing we want is for that graft to go behind the iris and into the capsular bag. So here's a little bit of myocall. Important to not have bubbles in the myocall here. It's not the end of the world, but it does become a pretty big nuisance when you're trying to unfold that graft. So really make sure there's no bubbles in that myocall and inject slowly. Pupil's coming down really nicely here. Now, I've been doing my DMEKs without a safety suture, so I like to pre-hydrate my wound and make sure that that wound is going to seal. If I were to end the case right here, then I would want to know that that wound is going to seal. And I see that the eye is holding pressure, so I feel pretty comfortable going ahead to insert the graft. And I prepped the graft ahead of time, and now I'm just trying to get it down into this modified Jones tube, and sometimes it just gives me a little bit of a hard time, so I actually have to tap on the side and just kind of loosen it up, and now it'll like to come forward, and I insert it enough so that I'm sure that the graft is going to go into the eye, and then I give it one last little push to push it away from the wound. And I can see it's unfurling pretty nicely already, but the S is backwards, so I know the first thing I have to do is make sure that I flip that graft around. I've got BSS in my right hand and air in the left hand, and I'm flipping it around using fluidics from the BSS. And now I trap the graft with my air cannula, shallow the chamber, and look at that. The graft is just unfurling so beautifully, so nicely. They do not all cooperate this nicely, but this one really did behave. And now I'm just trying to get the graft a little more centered, but it is already unfolded. So I'm just using this gentle sweeping motion to get it to the center. Important that the scrub tech is wetting the cornea with BSS constantly, because it's really easy to give these people corneal abrasion and accidentally have to do a superficial keratectomy while doing the DMEK surgery. So I'm just centering the graft here, and I like to go in through the main wound to fill with air. You can go in through the side as well. And I'm just going to fill it up and kind of top it off from the paracentesis. And here I've got a nice firm eye with about an 80 to 90% bubble, and the case is finished. Thanks for watching.